Welcome all to the today's class. So we continue with our pathology module, and today's topic for discussion is cell injury and cell death. So these two are different things, cell injury and cell death. Okay, and we will go into the details of this. Most of the time the SBs are asked on these particular concepts. Okay, so please listen to this particular today's lecture very carefully. You will get at least 2 to 3 SBs from this particular topic. So we'll start with the cell injury first. So what are the causes of cell injury? First is a hypoxia or ischemia. Okay, so it is the most common cause for the cell injury, and cause may be ischemia, cardiorespiratory failure, severe anemia, or carbon monoxide poisoning. Okay, it may be because of the physical agents such as trauma, mechanical injury, burn, then hypothermia, radiation injury, atmosphere pressure changes. These can also cause the cell injury. So commonest cause is going to be the hypoxia. Okay, and the physical agents can also cause like trauma, burns, hypothermia, etc. So if you see here, it is the hypoxia that causes reduced blood flow. Sometimes there is an inadequate oxygenation of the blood due to the cardiorespiratory failure. There can be decreased oxygen carrying capacity of the blood, as you see in anemia, carbon monoxide poisoning, or there can be severe blood loss. So there can be hypoxia, and because of this hypoxia, most of the time the cell injury there. And physical and chemical agents can also cause this cell injury. Infections and immunological causes can cause. Genetic causes such as Down syndrome, etc. They can lead to the cell injury. Nutritional deficiency or nutritional imbalance, in which there are both obesity as well as malnutrition, or it can be iatrogenic also. So infectious agents like viruses, bacteria, fungi, parasitic infections, or immunological cause like autoimmune disease, antigen antibody reactions, allergic disorders can lead to this cell injury. Sometimes there can be genetic defects like the sickle cell anemia or the Down syndrome. And sometimes there is intracellular accumulation of certain substances like fat, protein, pigments. They can have get accumulated inside the cell, and then they can lead to the injury to the cell. Next is a nutritional imbalance. As I mentioned, it may be both, either deficiency or excess. That is the protein calorie malnutrition, vitamin deficiency can lead to the cell injury, and sometimes it is the excess such as obesity, diabetes mellitus, atherosclerosis can also lead to the cell injury. So what happens in the basically in the cell injury? Mainly, we know that hypoxia is the most common cause. So this hypoxia and ATP depletion, this is the basic mechanism which is happening. So what happens because of the hypoxia? There is a decreased oxidative phosphorylation. So there is a decrease in the ATP, and the effects which are happening are because of there is a hypoxia, there is a anaerobic glycolysis which is increased. It leads to the increased lactic acidosis, decreased intracellular pH, chromatin clumping is there, ribosomal detachment is there. Once the ribosomes are detached, protein synthesis will get affected, and there will be cellular swelling. Okay, so these are the things which are happening. So in the ischemia, there is a decreased phosphorylation leading to the decreased ATP, and this is the mitochondria which gets hampered. There is a damage to the membrane of the mitochondria, and there is a decreased activity of the sodium pump. And once the sodium pump is damaged, there is a intracellular sodium which is increased, potassium intracellular is decreased, calcium is increased, and water is also increased, leading to the cell swelling. There is an anaerobic metabolism because of hypoxia, and because of which the glycogen will get depleted, and there will be metabolic acidosis. So pH will also be reduced. There is a failure of the calcium pump that leads to the increased intracellular calcium. Okay, and there are certain enzymes which will get activated. There are certain enzymes which will get inhibited also. So there will be certain decreased activity of cellular enzymes, and that leads to the clumping of the chromatin, and activation of enzymes that leads to the cell constituents damage. So certain enzymes which will can cause the cell constituents damage, that will increase. Okay, as I mentioned, there will be detachment of the ribosomes. Once the ribosomes are detached, there will be decrease in the protein synthesis. Okay, next mechanism is a free radical injury. Okay, first what we saw is a ischemia leading to the decreased ATP and phosphorylation, causing all these changes. Now, second mechanism of cell injury is the free radical injury, that is the reactive oxygen species, ROS will cause and such as the superoxide is there, hydrogen peroxide is there, hydroxyl radicals are there, and what they can do, there will be lipid membrane damage, protein denaturation will be there, DNA injury will be there, sodium potassium pump failure will be there, and ultimately there will be cellular swelling. Okay, so most of the effects will be same, but that is because of the free radical injury. And first what we saw is because of the decreased phosphorylation or the decreased ATP. Third mechanism is a increase intracellular calcium. Because of the increased cytosolic calcium, what happens is there is a activation of the phospholipases, activation of the proteases, endonuclease activation, and ATPase activation. So there are certain enzymes which will get activated. We have seen how the enzymes work in that particular mechanism of. So once the intracellular calcium is increased, these enzymes will get activated. That will cause the membrane damage, and also they will cause the mitochondrial injury. So what is the outcome of the cell injury? What we have seen up till now, one is the etiology. What are the different etiological factors? Then we have seen what is the mechanism of injury. Now we'll see what are the outcomes of the cell injury. See, this is the normal cell. Okay, this normal cell will get certain stimuli which will cause the cell injury. Suppose if it is just a mild stimulus, okay, the cell may feel that it is just a stress, and the cell will show certain adaptations. Okay, so the cell may show atrophy, cell may show hypertrophy, cell may show metaplasia. So there are different types of adaptations which are happening. We will go into the details of the adaptation after this. Okay, but if this persists, this injurious stimulus, that will lead to the cell injury. Okay, now, or sometimes there is a inability to adapt to the changes, that will also lead to the cell injury. Now this cell injury is of two types. It may be reversible, it may be irreversible. Okay, when the stimulus is mild or transient in nature, generally the injury is reversible injury and the cell will back to its normal functioning. But if the stimulus is a strong, severe, progressive stimulus, in that particular case, there will be irreversible injury, and that will lead to the cell death. And the cell death is of two types, necrosis and apoptosis. Okay, and generally they will ask you on either of this, necrosis or apoptosis, there will be SBA. There will be SBAs on these also. Okay, cell injury as such. Okay, and there are two types of cell injury, reversible and irreversible. The difference between the two also we should know. Okay, so what are the outcomes of the cell injury? As I mentioned, there will be complete recovery. This occurs in the reversible cell injury. Then there can be cellular adaptation such as atrophy, hypertrophy, hyperplasia, metaplasia, etc. Okay, so this is the normal cell, and when this normal cell gets exposed to the stress, there can be atrophy, there can be hypertrophy. What happens in hypertrophy is the cell size increases, the number remains constant. What happens in the hyperplasia? The number of the cells will increase. Okay, in both the cases, you will feel that the size of the organ is increased, but the mechanism or the differences also they are asking. So in hypertrophy, there is an increase in the size of the cell, while in hyperplasia, it is the number of the cells which gets increased. Then what happens in metaplasia? It is the change of one type of epithelium into other type of epithelium. And what happens in dysplasia? The cell loses its normal architecture and will become dysplastic with certain specific pathological changes. Now, third, there can be cell death. So what we have seen, there can be complete recovery, then there can be adaptation, or there can be cell death, that is necrosis and apoptosis. Next outcome is inflammation. The inflammation may be acute inflammation or chronic inflammation. And another outcome is a tissue repair. This repair will be by regeneration or the fibrosis. So this is what is the outcome of cell injury. Now we will see first the reversible cell injury. Okay, so in reversible cell injury, what happens? Cell changes will return to normal after the removal of the stimulus. So cell will come back to its normal once the stimulus is removed. What are the changes which are happening? Please remember the changes. Okay, in reversible cell injury, what change you get is a cellular swelling or the hydropic change. This is very important. Okay, this cellular swelling or the hydropic change you get in the reversible cell injury. The most common feature is that there is a ATP depletion and there is a sodium potassium pump failure that will lead to the water influx, and that will lead to the cellular swelling. Other features such as there will be loss of microvilli, membrane blebs, endoplasmic reticulum swelling will be there, mitochondrial swelling will be there, and chromatin clumping will be there. Okay, so these are the features which you will see with this hydropic change or the cellular swelling. This is a reversible type of cell injury. Now we go for the irreversible cell injury. What happens in the irreversible injury? It is the permanent injury which will lead to the cell death. Okay. Then what is the example? It is the myocardial ischemia. If it remains for a prolonged duration, there will be death of that particular tissue. Okay. So localized death of the myocardium will be there. Okay. So what are the features of irreversible cell injury? There will be severe mitochondrial damage. There will be membrane disruption. Lysosomal rupture will be there. Ribosomal detachment will be there, and massive calcium influx will be there. Okay, so what are the events in the irreversible cell injury? Again, there is a ATP depletion due to the mitochondrial dysfunction. There will be membrane damage. This is the very critical event in the irreversible cell injury. Remember, membrane damage. In reversible, what we saw? Cell swelling. Okay, but here there is a membrane damage. This is the critical event in the irreversible cell injury. Okay, and the consequences of the membrane damage will be loss of permeability control, calcium influx, enzyme activation, and protein denaturation. So these effects will be there because of the membrane damage. So in reversible type of cell injury, cell swelling. In the irreversible injury, you get a membrane damage. Okay, ATP depletion is seen in both. Okay, then coming to the ischemia reperfusion injury. Sometimes what happens? There is a initially decrease in the oxygen leading to the ischemia, but this is followed by the reperfusion. So we expect that there will be whatever the damage which has happened, that should stop. But practically it doesn't happen. There is a further injury when there is a reperfusion. Now, what happens when there is a reperfusion, that we'll see. So it is the paradoxical worsening of injury after restoration of the blood supply. So ischemia reperfusion injury, where there is a paradoxical worsening of the injury after restoration of the blood supply. Mechanism is ROS, reactive oxygen species. Okay, so once there is a reoxygenation, there is an increased reactive oxygen species production. Okay, there will be inflammation. Reperfusion will bring leukocyte influx. Okay, so there will be inflammation, and also there will be complement activation, antibody deposition that will activate the complement. So this is the ischemia reperfusion type of injury. Okay, now subcellular alteration and autophagy. Okay, so what happens here? This in autophagy, cell digests its own organelles during the starvation. So autophagy is a happens when the cell is starved for the longer time. Okay, so this is a different concept. Uh, Autophagy. So in autophagy, what happens when the cell is deprived, or when the cell is starving, the cell will digest its own organelles. The mechanism is that organelles are enclosed in autophagic vesicles. They will fuse with the lysosome and the digestion occurs. So what happens from the cell membrane itself? There will be some projections, and these projections will enclose these cell organelles. Okay, so these are the individual cell organelles, and this is the cell membrane. So there will be formation of the phagosome. So this cell membrane will encircle this and will form the separate phagosome. Now this phagosome will become complete, and this phagosome called as autophagosome. Now this autophagosome will join with the lysosome. We know that lysosome have got a various enzymes, or the digestive type of enzymes. So once this lysosome and this phagosome unite, at that time there will be lysis of these particular organelles. This is called as autophagy. Then what is the significance of this autophagy? The survival mechanism during the nutrition deprivation. So it is the survival mechanism of the cell during the nutrition deprived state. Okay, so there is a residual pigment which is formed, that is called as lipofuscin. Remember this. Okay, the specific pigment which is formed during this particular autophagy, when the cell organelles are digested, at that time the wear and tear pigment, also called as lipofuscin or the wear and tear pigment, that is getting formed. So take home message is that most common reversible cell injury, there is a cellular swelling. Most important mechanism of injury is a ATP depletion. Hallmark of irreversible cell injury is the membrane damage. Reperfusion injury mediated mainly by ROS, reactive oxygen species. Lipofuscin is the wear and tear pigment seen in autophagy, and calcium influx activates destructive enzymes. Okay, so these are the few concepts what we have learned. So same thing is given in the tabular form. Reversible injury, cellular swelling. Irreversible injury, membrane damage. ROS examples are the superoxide, hydrogen peroxide, hydroxyl radicals. ATP depletion will lead to the sodium potassium pump failure. Reperfusion injury is ROS mediated. Autophagy is the survival during starvation. That is the mechanism by which the cell will survive during the starvation period. And lipofuscin is the residual pigment. Okay. So next change we will see is the calcification. Okay. Calcification is the abnormal deposition of calcium salts in the tissues. There are two types of calcification. One is a dystrophic calcification, and this is a metastatic calcification. You should know the difference between the two. So dystrophic calcification, calcium deposition in the dead or damaged tissue despite normal serum calcium level. So in dystrophic calcification, here the calcium gets deposited into the dead or the damaged tissue, and the calcium level is normal. So in spite of normal calcium level, there is a deposition of the calcium, but it happens in the dead or damaged tissue. Okay, so characteristic is that calcium level is normal. Common sites are, it is seen in the atheromatous plaques, then tuberculosis granulomas, areas of necrosis, and damaged heart valves. Okay, histologically it will appear as a basophilic deposit. There may be intracellular or extracellular calcium deposition, and it may show bone formation also. Now next is a metastatic calcification. What happens in metastatic calcification? This calcification, or there is a deposition of the calcium in the normal healthy tissues due to the hypercalcemia. This is in contrast to the dystrophic. So here the tissues are normal in which the calcium gets deposited. However, calcium levels are high. Okay, so this is the basic difference between the dystrophic and the metastatic calcium. So here serum calcium level is high. It is seen in the kidney, lung, gastric mucosa, blood vessels, heart. Okay, then what are the causes of hypercalcemia? It may be because of hyperparathyroidism, bone destruction, vitamin D excess, or the renal failure. Okay, so what is the difference between the dystrophic calcification and metastatic calcification? So dystrophic is seen in the dead or damaged tissues. Serum calcium is normal. Example is tuberculosis granuloma. While metastatic calcification is seen in the normal tissue. Calcium level is high. It is seen in hyperparathyroidism. Okay. So next what we are going to learn is a amyloidosis. Okay. So amyloidosis is the extracellular deposition of the misfolded fibrillary proteins, also called as amyloid. Okay, this amyloid is nothing but the extracellular deposition of the misfolded fibrillary protein. So what happens here? The proteins are misfolded, and this misfolded protein will form the insoluble fibrils, and these insoluble fibrils, they will get deposited in the extracellular position, and that leads to the organ dysfunction. These fibrils are sticky in nature. Okay, see, this is the normally folded protein. A very compact protein is there, and this misfolded protein will be like this. This forms the amyloid. This is called as amyloid. So there are actually amyloid fibrils. They are sticky in nature. Okay, and they stick to each other, and they get deposited in the extracellular space. Okay, so there are different types of amyloid. So one is a AL amyloid, another is a AA amyloid. Okay, there are 4-5 types of amyloid. Few things about amyloidosis you should know. Okay, AL amyloid is a amyloid light chain. Okay, AL stands for amyloid light. Okay, light chain. So source is plasma cells, immunoglobulin light chains. This is seen in multiple myeloma or plasma cell disorders. Okay, so whatever comes to your in mind with light chain is the immunoglobulin. Okay, so plasma cells, immunoglobulin, that is the source of these light chains. This is L amyloid. Okay, seen in multiple myeloma, plasma cell disorders, etc. Second is a AA amyloid. Okay, this AA amyloid is derived from serum amyloid A protein. Okay, SAA, serum amyloid A protein. This is associated with a chronic inflammation. So rheumatoid arthritis, tuberculosis, chronic osteomyelitis, bronchiectasis, etc. Third is the ATTR amyloid. Okay, this is derived from transthyretin mutation. Okay, so ATTR amyloid is derived from transthyretin mutation. This is associated with the familial amyloidosis, senile cardiac amyloidosis. Next is a beta 2M amyloid. This is associated with the long-term hemodialysis. Okay, so long-term hemodialysis patients will have A beta 2M amyloid. Okay, next is the A beta amyloid. This is associated with the Alzheimer's disease. Okay, so this also you remember hemodialysis A beta 2M and A beta with Alzheimer. Okay, plain A beta is with Alzheimer and A beta 2M with hemodialysis. While AL you will be able to remember because it is a light chain. You remember multiple myeloma, plasma cell disorder. Okay, and AA amyloid with a chronic inflammation. And these are the examples of the chronic inflammations. Okay, so these are the examples of amyloid. Then what are the clinical types of amyloid? It may be primary amyloidosis. Generally, it is a AL type and seen in plasma cell disorder. Okay, secondary amyloidosis is AA type. It is seen with the chronic inflammatory disease. Okay, then there may be familial amyloidosis. It is associated with the familial Mediterranean fever. Then there can be endocrine amyloidosis. It is seen in medullary thyroid carcinoma, islet cell tumors. Then there can be senile cardiac amyloidosis. Generally, causes are the restrictive cardiomyopathy, cardiac arrhythmias. Okay. So clinical features of amyloidosis, generally the patient will have the weakness, weight loss, fatigue, etc. Various organs will get involved, hepatomegaly, splenomegaly, macroglosia, renal failure, cardiac arrhythmias, etc. Now, what is the diagnosis? The diagnosis of amyloid, pathological diagnosis, is with the help of special stain that is called as Congo red stain. So amyloid will stain pink or red with Congo red. Then apple green birefringence under the polarized light. So this Congo red stain, the amyloid will stain pink or red with this Congo red stain, and there will be apple green birefringence under the polarized light. Various organs are involved, such as kidney, that is the most common organ involved in amyloidosis. The patient will have the proteinuria, nephrotic syndrome, renal failure. In spleen, you will the look will be like a sago spleen. Okay, amyloid will be there in splenic follicles. Then there can be lardaceous spleen, diffuse splenic involvement. Okay, that is what is the picture. Either sago spleen or lardaceous spleen. In liver, the enlarged pale waxy liver will be present. Heart, there will be restrictive cardiomyopathy and arrhythmias. Okay, so in the amyloidosis, things to remember: best stain is a Congo red. Polarized microscopy will show the apple green birefringence. Then primary amyloid is a AL type of amyloid. Then secondary amyloid is a A type amyloid. Dialysis one is a beta 2 microglobulin, and Alzheimer's disease is A beta. Okay. So now we will see the cell death. Okay. So we have seen cell injury. If it is irreversible, ultimately it will lead to the cell death. And there are two types of cell death. Okay. One is a necrosis and another is a apoptosis. And there are differences between these two. Okay. So what happens in the apoptosis? The cell begin apoptosis. There is a membrane blebs are formed. So in the membrane, you get a blebs. Then there is a nuclear fragmentation and the membrane protrusions will be there. And after that, there will be cell fragmentation. Okay, see, this apoptosis is a very straightforward, very structured, organized way of cell death. Okay, so and it is ATP dependent. While necrosis is a sort of messy. Okay, it is not a program like apoptosis. So in necrosis, what happens? There is a cellular swelling. Cell begins here in the necrosis with cellular swelling. Rupture of the cell membrane is there, and the release of intracellular contents into the extracellular space, something like a blast. Okay, so there will be release of intracellular contents into the extracellular space. Okay, while here there is a first there is a membrane blebs, then nuclear fragmentation, membrane protrusions will be there. Then there is a cell fragmentation. There are apoptotic bodies which are formed, and then the macrophages will come and will engulf these apoptotic bodies. Okay, so necrosis is a sort of messy cell death. Apoptosis is a clean, organized cell death, like cell suicide as such. Okay, so let's see about the necrosis. Necrosis is the death of a group of cells in living tissue due to irreversible injury. Okay, it is associated with the membrane rupture, enzyme digestion, and inflammation. Okay, while in apoptosis there is no inflammation. Okay, so microscopic features: cytoplasmal changes such as increased eosinophilia, vacuolation will be there, myelin figures will be seen. Okay, nuclear changes will be pycnosis, karyorrhexis, and karyolysis. Pycnosis is the shrinkage of the nucleus, karyorrhexis is the breakage or the fragmentation of the nucleus, and karyolysis is the nuclear dissolution. Okay, so these are the cytoplasmic as well as nuclear changes which you see in the necrosis. Okay, so types of necrosis, you get the coagulative necrosis. On this also they are asking the questions, which necrosis is seen in this particular tissue. Okay, coagulative necrosis, architecture is preserved here, the tissue becomes firm. Okay, in coagulative necrosis, the architecture of the organ will be preserved. The tissue will appear firm. Generally, the cause is ischemia or the infarction. The commonly affected organs are the heart, kidney, liver. So, except brain, this is seen in rest of the organ. So, remember, this coagulative necrosis is not seen in the brain. This is also a SBA. Brain does not show coagulative necrosis. Okay. Coming to the liquefactive necrosis. So here the tissue will undergo liquefaction. There will be pus formation. Causes will be bacterial infection, brain infarction. Okay. Next type of necrosis is the gangrenous necrosis. It will be dry gangrene. That is the coagulative necrosis due to ischemia. It may be wet gangrene because of the superior infection. There can be gas gangrene because of the clostridial infection. Okay. Next type of gangrene is a caseous necrosis. Next type of necrosis is a caseous necrosis. Here you will get a cheese-like appearance and the granuloma formation. The classical example is a tuberculosis. This also you should remember. Okay, classical example of caseous necrosis is a tuberculosis. The next type of necrosis is a fat necrosis. This is seen in acute pancreatitis, breast trauma. Here, what is the mechanism of fat necrosis? There are the lipases. These are the enzymes which are released that will lead to the fat digestion, leading to the calcium soap formation, also called as saponification. Okay. Next type of necrosis is a fibrinoid necrosis. It is seen in the immune-mediated vascular injury, seen in the autoimmune disorder like polyarteritis nodosa. So in PAN, polyarteritis nodosa, you get immune-mediated vascular injury leading to the fibrinoid necrosis. So what is the mechanism of necrosis? There is a ATP depletion, there is a mitochondrial damage, calcium influx, ROS accumulation, and there is a membrane damage. Okay, because it is a cell injury, irreversible type of cell injury, ultimately it is the membrane damage is going to be there. So fate of necrosis, there can be resolution, there can be fibrosis and organization, and there can be calcification. Okay, now next type of cell death is a apoptosis. First type what we have seen was a necrosis. Now apoptosis, it is a programmed cell death affecting single cells or small group of cells. When the cell senses serious internal problems, it decides to self-destruct. So generally here, the signal for the apoptosis is coming from within the cell. Okay. So there are some serious internal problems because of which the cell decides to self-destruct. That is the apoptosis. Okay. So it is an energy dependent, gene regulated. There is no inflammation. There is a cell shrinkage and formation of apoptotic bodies. Okay. So these are the characteristics. So difference between the apoptosis and the necrosis you should understand. Okay. Now, what is the mechanism of apoptosis? There are two pathways. One is an intrinsic pathway and another is an extrinsic pathway. Intrinsic pathway is a mitochondrial pathway. So here, what happens in the intrinsic pathway? There is a This intrinsic pathway is triggered because of the DNA damage. Okay, because it is an irreversible cell injury, DNA damage is a part of it. So there is a DNA damage, loss of growth factors. There will be misfolded proteins. Okay, and this then what happens here? This basically there are in the cell there are pro apoptotic proteins and anti-apoptotic proteins. Okay, normally what happens, in this apoptosis, anti-apoptotic proteins which are there, they are inhibited, and pro-apoptotic proteins, they are stimulated. Okay, because of which there will be mitochondrial damage and there will be leakage of the from the mitochondria, and various especially the cytochrome C will be released from the mitochondria. Okay, so this cytochrome C will then activate this active uh, catas, caspase 9. Okay, so this cytochrome C will then activate active caspase 9. Then they will activate caspase 3 and 7 will get activated. Okay, and then the apoptosis will happen. Okay, so mechanism is a mitochondrial leakage leading to the activation of the caspase activation. Okay, so this caspase activation is there in this apoptosis in the intrinsic pathway, or there can be extrinsic pathway, that is the death receptor pathway. Okay, this is mediated by the TNF receptor family, or the cytotoxic T cells are involved here. While in intrinsic pathway, it is the mitochondrial leakage leading to the activation of the caspase, that is the mechanism. In extrinsic pathway, TNF receptor family and cytotoxic T cells are involved. Then what is physiological apoptosis, which happens in the embryogenesis, endometrial shedding, hormonal withdrawal, and aging. Then there is a pathological apoptosis, which happens in the viral infection, radiation injury, tumor regression after chemotherapy. What is the morphology of apoptosis? There is a cell shrinkage, eosinophilic cytoplasm will be there, nuclear fragmentation will be there, and the apoptotic bodies are formed. This apoptotic bodies is one of the important feature of this apoptosis. Okay, so the difference between the necrosis and apoptosis we will summarize now. So what happens in apoptosis? ATP is required here. Gene regulation is there. So it is genetically regulated. Cell lysis is not seen. Inflammation is not seen. It may affect the single cell or few cells. Generally, it is a physiological or it may be pathological also. So apoptosis is energy dependent, genetically regulated. There is no cell lysis. There is no inflammation. It may affect single or multiple cell. It may be physiological or pathological, while necrosis is always pathological. Okay, ATP is not required. It is not genetically regulated. Cell lysis is seen here, while here apoptosis, there is no cell lysis. Okay, there is an inflammation. In necrosis, a large group of cells are affected and it is always pathological. So these are the features and the differences you should remember between the apoptosis and necrosis. So take home message is that coagulative necrosis is because of the ischemia in the solid organs. Then liquefactive necrosis, brain infarct is the example of liquefactive necrosis. Caseous necrosis is seen in tuberculosis, fat necrosis, acute pancreatitis, fibrinoid necrosis, vasculitis. Pycnosis is the nuclear shrinkage. Karyorrhexis is the fragmentation of the nuclei. Karyolysis is the dissolution of the nuclei. Then apoptosis does not cause inflammation, and caspases are key enzymes in the apoptosis. So this you should remember. Okay, so the initial part up to the cell death we have finished. Okay, now we have to see cellular aging and cellular adaptation. In the beginning, what we have seen, that there is a cell, normal cell. This cell, when gets a stimulus which causes injury, okay, then if the stimulus is mild, the cell may undergo certain adaptation. Okay, this is what. And if the cell is functioning, then also cell can have the aging. So what is this cellular aging and what is cellular adaptation, that we will see. Okay, and if the stimulus continues, then what happens? It may be irreversible type of injury or the irreversible type of injury. If it is irreversible, it will lead to the cell death, which may be necrosis or apoptosis. This is what we have seen. Now we have to see natural cell aging and cellular adaptation. Okay, so what is cellular aging? Okay, a progressive decline in cellular function and reparative capacity with advancing age. Okay, that is the cellular aging. What is the mechanism of aging? It is because of the accumulation of the DNA damage. Okay, so cause is defective DNA repair, free radical injury over the period of time, and result is a progressive cellular dysfunction. Okay, second mechanism is a replicative senescence. Okay, there is a progressive shortening of the telomeres and reduced telomerase activity. So result is a reduced ability of the cells to divide. This we have seen when we were studying about the genetics. Okay, uh, basically the ends of the chromosomes, they are the telomeres. Okay, and these telomeres are protective. Okay, so what happens when the cell divides? There is a progressive shortening of this particular telomere, and this telomerase is the enzyme which has got a capacity to rebuild this telomere, okay, which are getting shorter. But what happens? There is a progressive shortening of the telomere with multiple cell division, but there is a reduced telomerase activity, and the result is a reduced ability of the cells to divide. So what happens? The cell will stop to divide further. That is the replicative senescence. The cell will divide, and it will stop further dividing. Okay, so this is the replicative senescence. Okay, so causes we have seen, there can be accumulation of the DNA damage, there can be replicative senescence. Third is there can be metabolic damage, which may be because of accumulation of oxidative stress, cellular injury, growth factor mediated damage, etc. So DNA damage, mainly it can be free radical injury, senescence because of the telomere shortening, telomerase activity is reduced. So there is a reduced cell replication. Okay, so this is what is the cellular aging. Okay, now we'll see next concept, that is the cellular adaptation. So some part of cellular adaptation we have discussed, but we'll see in detail. So what is the definition of cellular adaptation? Reversible structural and functional changes that allow cells to survive stress and injury. So these are the reversible structural and functional changes, okay, which allows the cell to survive. When there is a stress and injury, the cell survives with these adaptation because of these. So these are the adaptive changes which are happening in the cells. They what are the changes? It may be atrophy, hypertrophy, hyperplasia, metaplasia. Okay, so what is atrophy? It is the decrease in the cell size due to loss of cellular substance and reduced metabolic activity. So atrophy, there is a decrease in the cell size, not the number. Okay, so atrophy, there is a decrease in the cell size due to loss of cellular substance and reduced metabolic activity. Note, cell number remains unchanged here. It is the cell size, and effectively the organ size will reduce. Okay, so what are the causes of atrophy? One, there can be decreased workload, loss of innervation, reduced blood supply, malnutrition, loss of endocrine stimulation, and aging. That is the senile atrophy. So these are the causes of atrophy. What is the pathogenesis of atrophy? In mechanism, there is a decreased protein synthesis, increased protein degradation, ubiquitin proteasome pathway activation is there, and increased autophagy. Okay. Now, what is autophagy? that is the self-eating process where starved cell digest their own organelles for survival. This also autophagy we have seen. The cell will eat the self organelles. Okay, and this is the mechanism by which the cell will survive when there is a starvation. Okay, there are types of atrophy. One, it may be physiological atrophy, such as thymic involution after puberty. So this is the physiological atrophy. That is the thymic involution is there after the puberty. There can be nutritional atrophy. That is the cachexia in the chronic disease. There can be disuse atrophy, like immobilized limb muscles. Okay. Then there can be neuropathic atrophy, poliomyelitis causing the limb atrophy. Then endocrine atrophy, such as pituitary failure causing the thyroid and adrenal atrophy. Okay. So there is a difference between atrophy and hypoplasia. Okay. So we should remember atrophy when happens, initially the organ is normal. So the organ is well developed. And after that, this atrophy sets in. Okay. So after normal development, the atrophy will set in, while hypoplasia will happen during the development. Okay. So mechanism in atrophy is a shrinkage, while in hypoplasia, it is a failure to develop. Okay. Example of atrophy is a muscle wasting, while hypoplasia example is achondroplasia. Okay. So atrophy happens after the development, while hypoplasia begins before the development of the organ itself. Okay. So atrophy we have seen. Now next adaptation is a hypertrophy. What happens in hypertrophy? There is an increase in the cell size. Remember, hypertrophy, there is an increase in cell size causing enlargement of the organ size. There is no increase in the cell number in hypertrophy. There is an increased workload. Hormonal stimulation can lead to the hypertrophy. Then what are the types of hypertrophy? It may be physiological, such as uterine enlargement, which happens in the pregnancy, or skeletal muscles in athlete. They will show physiological hypertrophy. It may be pathological, such as cardiac hypertrophy, which happens in hypertension. It may be aortic valve disease. Okay. Then what is the mechanism of hypertrophy? So there is a stimulus. This stimulus activates gene leading to the increased structural proteins that leads to the increased organelles and the cell size increases. Okay. So cardiac muscle will undergo hypertrophy only because adult cardiac cells cannot divide. So generally what happens, this hypertrophy is seen in the tissues where the cell cannot divide. So the cellular response will be by increasing the size, because here the cell cannot divide. Okay. Now next type of adaptation is a hyperplasia. Now hyperplasia, here there is an increase in the number of the cells causing enlargement of the organ. It occurs only in tissues capable of cell division. Okay. So hyperplasia will be seen in only those tissues where the cell division is possible. Okay. So types of hyperplasia, again, it will be physiological hyperplasia, like hormonal hyperplasia, breast enlargement in puberty, pregnancy, etc. It may be compensatory hyperplasia, like liver regeneration, or hyperplasia of remaining kidney after nephrectomy. Okay. Or it may be pathological hyperplasia, such as because of the excess hormones or growth factor stimulation, etc. So examples of pathological hyperplasia: endometrial hyperplasia, viral warts such as papilloma virus, fibroblast proliferation in wound healing, etc. The clinical importance is that persistent hyperplasia may predispose to the malignancy. Okay. Examples are endometrial carcinoma, cervical cancer after HPV infection. Okay. So that is the persistent hyperplasia which may predispose for the malignancy. Then sometimes there is a hyperplasia without hypertrophy. Okay. Hyperplasia is the increase in the number of cells and without hypertrophy, like bone marrow hyperplasia, which happens in anemia. Then compensatory renal hyperplasia. Okay, here the cells number is increased. Sometimes there is a hypertrophy without hyperplasia, like skeletal muscle hypertrophy, cardiac hypertrophy, pyloric stenosis. Here the muscle size is increased, but not the numbers. Okay, so there are important differences between the hypertrophy and the hyperplasia. In hypertrophy, cell size is increased, number is constant. There is no cell division. Okay, it is seen in non-dividing tissues. While in hyperplasia, cell sizes remains normal, but the cell number is increased and cell division is also increased, and it is seen in the tissues which divides. Okay, cell where the cell division is happening. Okay, now next type of adaptation is the metaplasia. What we have seen up till now, atrophy we have seen hypertrophy, we have seen hyperplasia. Now next is a metaplasia. Metaplasia is a reversible replacement of one mature cell type by another mature cell type. So in response to the stimulus, the cell will change the architecture. Okay, so one type of epithelium or one type of tissue is getting changed into other type. Okay, so mechanism is a genetic reprogramming of the stem cells is there. Purpose is adaptation to chronic stress or injury. So what are the common types of metaplasia? So there can be respiratory epithelium normally, which is the ciliated columnar epithelium. These normal epithelium types of epithelium are also asked in the examination. Okay, different types of epithelium you will be asked. So respiratory epithelium is a ciliated columnar type of epithelium, which will change to the stratified squamous epithelium, maybe because of the cigarette smoking or vitamin A deficiency, where the ciliated columnar epithelium of the respiratory tract will become the stratified squamous epithelium. Then there is a Barrett esophagus. What happens? Normally there is a squamous epithelium that will become the columnar epithelium. Okay. So here the squamous will become into columnar. Okay. Which is exactly opposite to the cervix. Okay. So in Barrett's esophagus, squamous epithelium will change to the columnar epithelium. That is because of the chronic GERD, gastroesophageal reflux disease. Then you have bladder metaplasia. Normally epithelium is a transitional epithelium that will change to the squamous epithelium, maybe because of the chronic stone. Next is a mesenchymal metaplasia, where the fibrous tissue will uh, be converting into bone formation. Okay, it happens because of the trauma. Then what are the complications of metaplasia? There can be loss of normal function. There can be dysplasia. There is increased cancer risk. Okay. Examples are the lung cancer in smokers. There can be cervical malignancy. Okay. So these are the complications of metaplasia. Now take home message is that atrophy is the decrease in the cell size. Hyperplasia is the increase in the cell number. Hypertrophy is the increase in the cell size. Metaplasia is reversible. Barrett esophagus, where the squamous type of epithelium is converted into columnar type of epithelium. Smoking causes squamous metaplasia. Cardiac muscle undergoes hypertrophy only. Ubiquitin proteasome pathway is involved in the atrophy, and telomere shortening causes cellular aging. Okay, so this is what about the cell injury. Okay.
Question number 1. A patient developed myocardial ischemia for a prolonged duration leading to irreversible injury. Which of the following is a hallmark of irreversible injury? Option A, cellular swelling. Option B, increased anaerobic lipolysis. Option C, membrane damage. Option D, chromatin clumping. Option E, loss of microglia. Sir, option C, membrane damage.
Yes, irreversible injury, membrane damage. Okay. So membrane damage is the key event in irreversible cell injury. Loss of membrane integrity causes calcium influx, mitochondrial dysfunction, and leakage of cellular contents leading to necrosis. Next, doctor, continue.
Question number 2. Which of the following reactive oxygen species is the most toxic to cell? Option A, hydrogen peroxide. Option B, superoxide radical. Option C, hydroxide radical. Option D, nitric oxide. Option E, carbon dioxide. Sir, option B, superoxide radical.
Hydroxyl, option C, hydroxyl. So hydroxyl radicals are highly reactive free radicals causing severe lipid peroxidation, DNA damage, and protein denaturation. Actually, these all three are ROS only, among which hydroxyl radicals are the most, you can say, dangerous. Next.
Question number 3. A brain infarct most commonly undergo which of the following necrosis? A, coagulative necrosis. B, fat necrosis. C, caseous necrosis. D, liquefative necrosis. E, fibrinoid necrosis. So option C, liquefative necrosis.
D, liquefactive necrosis. Okay. So ischemic injury in the brain characteristically causes liquefactive necrosis due to enzyme digestion of dead tissues. Okay, next.
So question number 4. Which stain demonstrate apple-green bifurcations under polarized light in amyloidosis? A. Pass stain. B. Congo red stain. C. Zn staining. D. Monsoon strikum. E. Southern blue. Sir, option B. Congo red stain.
Yes, with Congo road, it is specific for the amyloidosis. Okay, Congo road stain. Amyloid stained with Congo red demonstrates apple green birefringence under polarized microscopy, which is diagnostic. Next.
Question number 5. Secondary amyloidosis is the most commonly associated with which of the protein? Option A, AL protein. Option B, ATTR protein. Option C, beta 2 microglobulin. Option D, AA protein. Option E, AB protein, A beta protein. The secondary is associated with
option D.
Yes,
option
it
D,
is.
AA protein.
Yeah, AA proteins. AL is a primary. Okay,
Primary.
light chain, then plasma cells and
Plasma cell
multiple
immunoglobulins.
myeloma. Okay, all these you should know go hand in hand. Okay, and amyloid AA protein, chronic inflammation. Okay. Uh, Dr. Sansi, few questions you take now. So secondary amyloidosis occurs in chronic inflammatory conditions and is composed of A amyloid derived from serum amyloid A protein. Okay. So at least you are getting the concepts when you read the question. Don't blindly you recall the theme behind it. Dr. Sansi, please go through these questions now here onwards.
Yes, sir. Which nuclear change in necrosis refers to nuclear fragmentation? Pyconesis, karyolysis, karyorhexis, calcification, autolysis. Sir, option C, karyorhexis.
Yeah, rhexis is a fragmentation. Okay. So it is a karyorhexis. Karyorhexis means fragmentation of the nucleus. Pycnosis is the shrinkage. Karyolysis is a dissolution. Next.
Fat necrosis is classically associated with which condition? Sir, option C, acute pancreatitis.
Yes, fat necrosis is a classically you get in acute pancreatitis. Okay. So pancreatic lipases digest adipose tissue causing fat necrosis and saponification with calcium deposition. Next.
Which statement regarding apoptosis is correct? It causes intense inflammation. ATP is not required. It affects large group of cells. It is genetically regulated. Sir, option D only. It is genetically regulated.
Yes, it is. It is a programmed, okay, well planned cell death. Okay, genetically regulated. Okay. Apoptosis is an energy-dependent programmed process regulated by apoptotic genes and caspases. Okay, caspase 9, then 3 and 7 are coming into picture. Next.
A chronic smoker develops replacement of bronchial columnar epithelium by squamous epithelium. This is an example of metaplasia. Sir, option D.
Yes, change of one type of epithelium into other type is a metaplasia. Metaplasia is a reversible replacement of one mature cell type by another mature cell type due to chronic stress. Next.
Which of the following is an example of physiological hyperplasia? Endometrial hyperplasia due to excess estrogen, benign prostatic hyperplasia, liver regeneration after partial hepectomy, left ventricle hypertrophy in hypertension, squamous metaplasia in smokers. Sir, option C, liver regeneration after partial hepectomy.
Partial hepatectomy, then there will be, that is a physiological hyperplasia. Compensatory hyperplasia following liver resection is a physiological form of hyperplasia. Yes, next.
Which pathway is mainly responsible for degradation in cellular atrophy? Pathway response in atrophy. Sir, option C, ubiquitin proteasome pathway.
In cellular atrophy, ubiquitin proteasome pathway. Atrophy involves increased protein degradation through the ubiquitin proteasome pathway. Next.
Barrett esophagus is characterized by squamous to columnar metaplasia. Sir, option A only, squamous to columnar
Yes,
metaplasia.
squamous to columnar epithelium. Okay. So chronic GARD causes replacement of normal squamous epithelium by intestinal type of columnar epithelium. Next.
Which of the following tissues undergo hypertrophy but not hyperplasia in adults? Only hypertrophy. Endometrium, liver, bone marrow, cardiac muscle, breast glandular tissue.
Cardiac muscle.
Cardiac muscle.
Correct,
Option
cardiac muscle, because they cannot divide. They will have to undergo hypertrophy only. So adult cardiac muscle have minimal capacity for cell division. Therefore, adaptation occurs by hypertrophy only. Next.
Which of the following is the most characteristic feature of dystrophic calcification? Occurs in healthy tissue associated with hypercalcemia, occurs in dead tissue with normal calcium levels. Sir, option C only, occurs in dead
Yes,
tissue with normal
dystrophic
calcium.
calcification, dead tissue with normal calcium. Okay. So occurs in dead tissues with normal calcium. Dystrophic calcification occurs in necrotic or damaged tissues. Next.
Telomere shortening is primarily associated with cellular aging. Option B.
We stop here. We finish today's topic of cell injury and cell death. Thank you very much. Okay.
Yes. Thank you, sir.
Thank you.
Thank you, sir.